Hi, this is Dr. Torino, and I'm here with this episode of UltraSoundbytes from EVMS, and today we're going to talk about the eFAST exam. At EVMS, we're not really going to focus on a FAST by itself. We're going to expand that to include lungs. That's an eFAST. So today we're going to talk about that clinical application, the machine setup, the patient setup, your acoustic window for all of the required images, some pitfalls and pearls to scanning, and then an introduction to the scanning cards that will be available as scanning prompts to help you when you are scanning clinically. Remember that ultrasound and trauma really is based around a point of care ultrasound, and the foundation scans for that are a FAST scan or an eFAST. The difference is the expansion of the FAST exam to include the thorax, and that really was the push for that. So instead of just having abdomen and pelvis images looking for free fluid, now we will examine the heart as well in one of our 3 image possibilities, and lungs to make sure there's lung sliding and pulmonary motion. So we're going to use a phased array transducer, since that is the universally useful transducer. It is potentially possible for you to change your exam as you scan, but it isn't preferable. This is an exam that is going to be done when patients are often unstable, and any change you make is going to eat up valuable diagnostic time. The one exception to that will be that I will change my exam presets as I am conducting this exam. You'll see that happen. So we're going to, I'm going to stay with a phased array transducer. I'm going to use a cardiac preset for my cardiac and lung images, and then an abdomen preset for everything else. In clinic, you should be labeling at least an identifier for the anatomy, and often you won't have time to do that in real time. It might have to be added after the fact. So we're going to go step by step and first review it and then to scan it through our images. And the first image I will get is the image that I'm presenting first, and it's going to be cardiac. I start with heart because that is the most important item to document for this patient. So regardless of where they are in this list, each of you are going to find your own protocol that will be comfortable for you. I'm going to step you through a parasternal, an apical, and then a subcostal view so we can pick the best view. If I were scanning a true eFAST, when I get to the first acceptable view, I'm going to get that clip and I'm done. Then I am going to clear the anterior lung fields. I will clear first left because I'll be on the left for cardiac, and then I'm going to go to the right lung field. At that point, I'm going to change my preset. I'm going to do right upper, then left upper quadrant, and then the bladder. And the bladder must be scanned sagittal and transverse, 2 scan planes. So since I'm going to start with heart, we're going to talk about the probe marker for cardiac. It is going to start in a cardiac preset, so my notch is going to go to the patient's right shoulder. Remember, when you use settings like a FAST setting as a preset, then your notch is opposite and would have to go to the left hip. We're going to use the standard motions of our probe, a heel toe, sweep, and pivot and rotate. So all of them are going to come into play. And although you could change your patient position if your patient is able, again, remember these patients are often trauma patients, and so supine typically is how you're going to scan these patients. I'm going to begin my cardiac scanning at a parasternal long axis view. Our standard anatomy, starting anteriorly, right ventricle, aorta, left ventricle, here's my ventricular septum, mitral valve, and left atrium. Important to this image is going to be our ability to see the pericardium to make sure there's no pericardial effusion. And the documentation of the descending aorta is going to be a very good visual ID for you to decide if you have enough depth or not. Typically, if you can see the entire descending aorta, you're going to be able to see a pericardial effusion if it's present. You are going to be putting your probe somewhere between about 2nd to 4th intercostal space. You can see here how close you're going to stay to the sternum. And again, in cardiac preset, notch to the right shoulder. The other information you get from your cardiac views, besides the immediacy of pericardial effusion, is a quick eyeball of how well their heart is functioning. And if their heart is functioning well, like this heart on the left, you're going to see the anterior mitral valve leaflet coming up here and approaching or slapping against the interventricular septum. When you have patients with decreased ejection fractions, you can see valvular function is reduced, chamber size begins to increase because the heart is not pumping and cycling blood adequately. On parasternal long axis, if there is an effusion, you might be able to see pericardial effusions as well as pleural effusions. Sometimes in this view, a pericardial effusion is called a rat's tail because of that appearance. And again, you can see, if I had that descending aorta in view, I might not have seen all of that pleural effusion, but I sure would know it's there so that I could adjust my depth accordingly. Our second cardiac window that is a real go-to window is going to be subcostal or subxiphoid with a probe marker just inferior to the xiphoid, maybe off a little to one side or the other. If you are in a cardiac preset, the notch is going to go straight to the patient's left. And again, remember, in a fast preset, the notch would be opposite. Same probe maneuvers will be useful. Again, patient's really going to be supine for this entire process. And then you are going to angle your probe sharply superior and perhaps a little to the patient left. So remember that subcostal views may actually become your go-to view all the time, because this will be the view that is not going to interrupt any procedures that are going on at the anterior chest wall. Notice that you may have to change how you hold your transducer so that you can angle sharply enough superiorly. So from cardiac, I am going to scan lung. We're going to review the kidney-liver interface first. They're just a little different sequence than I'll be using. So at this point, you're really mid-axillary and somewhere between the 8th and 11th rib. You're going to keep notch towards the patient's head. And what do you see? You see liver and you see right kidney. What are you looking for? you're looking for the presence of fluid. Here's a little bit of ascites or perhaps hemoperitoneum, and then you're going to look to see if there's any pleural effusion superior to the diaphragm, which we don't see in this patient. If in this view you cannot see the entirety of Morrison's pouch, you need to make sure that you slide inferiorly and get that lower pole. If you don't see the diaphragm, you need to angle or slide superiorly and look there as well so you don't miss that pleural effusion. From the right upper quadrant, we're going to transition, but I want to talk about a clinical pearl at this minute first. Think about what I said. I said that the potential fluid is either acidic, clean fluid, or it's blood, hemoperitoneum. Blood is going to be tricky for you, potentially, because the appearance of blood changes as it ages. Brand new blood, which is still quite liquid, is anechoic. It's black in appearance. But then you see at the top, blood will begin to lay down little strands of fibrin. You can even see a few of them on the bottom image. And you'll begin to see slight but quite hypoechoic echoes throughout. Eventually, they will come to fill the blood, whether it's truly like a hematoma or that region, and it'll continue to mature, and it will become more hyperechoic and organized, and eventually the entire structure will be quite hyperechoic. And then finally, the blood will begin to resolve and very slowly decrease in size. At this time, I want to do an SPI snapshot, and it's going to be talking about the tissue types in our body. And I want to talk about this today because we're talking about looking at images and looking at fluid or blood. So in our body, we have very big reflectors, like our diaphragm or our kidney-liver interface. And we call these specular reflectors. Specular reflectors send bright interfaces back to the body, and sound goes in, and sound will come back, straight back to the machine. But that only happens in very limited scenarios. What we get a lot more is scattering, and scattering occurs when sound goes into the body, but it hits smaller objects and it goes back to the machine in many different directions. It is scattered. Now, some scatterers are about the same size as our beam. That's tissue. Our molecules are little islands of parenchyma. These are called diffuse scatterers. They can be tricky because they may or may not create a shadow that you can use to make a clinical diagnosis. The smallest targets in our body are red blood cell size, and these are called Rayleigh scatterers. They don't ever block the beam, and we don't see them very often. We see them often in venous structures where blood is not moving as quickly. So think about what you're looking at, and it will help explain the echoes you see on your image. All right, so now we're going to talk about the splenorenal interface. So you need to see that interface all the way to the lower pole of the left kidney, just like on the right, and you need to be able to see the diaphragm to look for potential pleural effusions. What do we see in this image? We see spleen, we see left kidney. There's no fluid between the spleen and the left kidney, but there is fluid or blood superior to the spleen. And so you need to, again, you're scanning axillary, mid-axillary line, probe to the patient's head. And remember, the spleen is little. Your probe is going to be quite high. Start at the natural waist, mid-axillary, and go north until you find a kidney or a spleen. Then we're going to go to the pelvis, and pelvis must be documented in 2 scan planes. And what I want you to remember is when we think about pelvis and bladder, we call it a bladder shot for FAST, you think about setting your depth only for your bladder, but really, the potential spaces are deep to the reproductive organs. That's where fluid is going to go first because fluid is going to settle dependently. So you want to make sure that you're deep to either uterus or prostate so that you can see the posterior cul-de-sac. That's at the yellow arrow. There are 3 potential spaces that you're looking at in this view, which is why it's important enough to require 2 different scan planes. The second scan plane you have to worry about is the anterior cul-de-sac. And finally, you have to worry about the very, very anterior space of Retzius, which is just deep to the subcutaneous tissues. So please be aware that you're looking at multiple spaces and watch your depth. So here you can see 2 clips through the pelvis, 1 long, 1 transverse. Notice nice depth deep to, in this case, the uterus, so that we're sure if there's any dependently layered fluid, we would see that. And then we're going to clear, again, I'm going to clear left lung field first and then right. So we're going to clear our anterior lung fields, and you're going to keep your probe sagittal at about mid-clavicular line, quite superior. You want to be sagittal because now you're going to have 2 ribs that become good landmarks so that you can see that pleural interface and watch that sliding if it's present. Again, if you have time, go to a linear probe like this. But if you don't, and I'm not going to take that time, I'm going to stay with my phased array probe and I'm going to decrease my depth. It's not as pretty, but I can still see everything that needs to be seen to make a diagnostic decision. So you're going to document this image on the right and left side of the sternum. Remember, when you look at pleural tissues, you're looking for movement, that's sliding, and you're looking for A lines which sit horizontally and B lines which sit vertically. And remember, those B lines, if you have many, many B lines, you have to worry that there is edema in the lungs and that the lungs are not filling with air accordingly. So you want to pay attention to those. So now we are going to go scan. Remember, it's called FAST for a reason. Based on guidelines, you have a maximum of 5 minutes. A lot can happen to a patient in 5 minutes. When you work in the emergency department, they are going to request that you scan this in less than 1 minute. So you really need to get what you can get as nicely and pretty as you can get it, with worrying much more about the diagnostic quality and much less in this scenario about the image quality, as much as it might pain me to say that. Because we are going to be doing this as a FAST exam, I'm going to leave a little pile of gel in all my spots. And I'm going to go thorax first, and then I will gel the abdomen. So I'm going to start with a parasternal window. Ooh, nice hairy chest, extra gel, so sorry. And there we go. So really, this is a beautiful window. I wouldn't go any further. I would have taken about 2 clips, 2 heartbeats, excuse me, saved my cine, and moved on. But I do want to show you that I'm gonna examine the apical 4 chamber. Let's just make sure I could use it. You could use it if it were required. And the one that all patients hate, subxiphoid. I'm gonna start with my probe kind of leaning up and facing superiorly, and then I'm going to, because I know he's able, ask him for that breath in. Big breath for me. If your patients, there you go. If they're able, let them. But if they can't, you get what you can. Breathe. If my patient couldn't take in a breath, I still can see the pericardium to decide if there's a big effusion. I still can see squeezing of the ventricular walls. I certainly don't see the base of the heart, the atria, very well. But from here, I'm going to take my probe. I'm going to go mid-clavicular on the left side. Now, I don't see very much, so I'm going to decrease my depth. I'm still in a cardiac preset, and I'm going to turn my gain way up so that you can see between this rib and this rib. Here is my pleural interface, and look at this. Here's a little air bubble, and watch it move. Now just taking a nice breath and let it out. And there you see some sliding. That's all I need. Done. Now I'm going to come to the right side of the thorax. Same thing. I'm going to come in between 2 ribs. Here a rib, here a rib. My pleural interface. I see some A lines. They are very normal, don't care. And I see sliding, the little seashore sign for his lungs. Very nice. Done. Now, I'm going to quickly blob right, blob left. Watch the goosebumps come up. And I'm going to change my depth. Now look what's happened. I changed my depth. I did not change my preset. And my image is backwards. I'm going to really quickly now go to adult abdomen. It takes me only a moment. I still have time to look through my entire Morrison's pouch. And there's my image saved. Now I'm going to reach over to the left side. I see spleen, so I know I've gone superiorly enough. I'm going to rotate a little clockwise to try and pull in this interface a bit better. I see no fluid. Done. Now I'm going to come inferiorly, some gel. I'm going to have notch towards the head, and I'm going to angle quite inferior. And I have a clinical, so here's my sagittal bladder done, but look, there's no bladder visualized. He just went to the restroom, bad patient. So when you don't see the bladder, how do you know if you're inferior enough? Look at these, these rectus abdominis muscles. As your rectus abdominis muscles come into the pelvis to insert on the pubis symphysis, I'll be able to tell if you are inferior enough because they start to dive deeper into the image as that image field goes inferiorly. That's my landmark to know if I have looked far enough. So now I'm going to move to my pelvis, and I am going to angle quite inferiorly. Here's a little bit of urine in the pelvis. There's my image. I'm going to save it. But I have a clinical item I want to pull up for you and discuss, and that is, what do you do when somebody does not have a full bladder? I want you to look at these anterior rectus abdominis muscles, and you'll be able to decide if you're inferiorly enough, because you will see these muscles diving posteriorly as you move inferiorly, and when they dive deep, that is your proof that you are as inferior and as deep in the pelvis as that bladder is. So now I'm going to put notch to the patient's right. Again, very, very sharp inferior tilt. I don't see any free fluid surrounding the bladder. There's my clip, and my eFAST exam is done. All right, so I'm going to leave you with this second or third, perhaps clinical pearl, and it's just an algorithm for you that you may find helpful as you go into your clerkships and then further ahead into your residency. And in any of these scenarios, eFAST is a great way to start. There's no radiation involved, and it is very quick and very portable. So we encourage you to make that part of your regimen. That's it for me. I hope you can stay tuned for the next sound bites from EVMS, and I hope you explore Blackboard to find your scanning reference cards for an eFAST exam. Thank you.